One classical test just to look for the facet joints without activating the deep muscles is actually to get the patient to extend the neck, rotate it, and then you cause pressure. So you actually compress the facet joints. It's a general kind of examination to see if there's any form of facet joint or foraminal encroachment due to osteoarthritis. You eliminate the osteoarthritic component by eliminating they have pain into the arms. If they have that, you might know there's going to be some limited space for the nervus leaving the spine. You do that to both sides and ask the patient if that reproduces their pain. So often you have to hold the head for some time and then you ask the patient, is that the pain you normally have? Something. Okay. And what kind of pain do you normally have? Just general pain in the neck?
Stiffness and maybe some radiation or some maybe disease.
Okay, right here, you don't get it into your fingers? Okay. So I'm just going to have a feel with this patient here, just in general. First of all, he's done some active movement. I just want to feel how his joints are moving, and you can do that very slowly. It's not too bad here. We'll just try the other area. Here's a little bit of stiffness. And stiffness here at the lower level leg. Then I would like the patient to lie down. Face up. Face up, yes. Everybody can do this in a little bit practice. So you have them lying in a usual position. And then you want the patient to relax. By doing this here, you won't have any joint compression or muscle tension when they lie down. So you might be able to sneak in and have a feel what's going on there. So you find the spinous process in the middle of the neck. It's very easy to palpate. And you just go about 1 centimeter lateral. And then you just go in, and then you'll have the facet joint just underneath your finger. A little bit of extension, you can go in and press on the facet joint and test it and ask the patient if it causes any pain. I go further down and further down still. Here there's no tension in the muscles, so I won't be able to provoke them. I'm going to do the same on the other side here. And I'm going to press in on the facet joints. No obvious pain? No? Okay. Then you go in just lateral to the spinous process with a slight extension of the neck, and you just put your middle or index fingers up, and you go deep into the muscle tissues here, and you ask the patient, is there any pain in here? Some? Any radiation? Okay. If there's a trigger point in there, and if you press hard enough, you have to press hard. Don't be a sissy. Really press hard. And you go in here, so you have to actually feel the lamina under your fingers. So you have to compress the outer muscles, and you have to feel something hard underneath. And I go further down. And still further down. It doesn't seem that bad here. I would like the patient to lie on the stomach. When I just scanned the patient here, sitting up, if I press in here, pain here, so I'm just pressing on T1 here, and that's actually blocked, and I can see it's painful when I press the joint. And I'm just pressing on the spinous process, so I'm not really touching the muscles, I'm just testing by compressing the joint and rotation. So if that causes pain, there's going to be some facet irritation. If there's facet irritation, there's always going to be spasm at the deep intervertebral muscles. As you all know, the cervico-thoracic junction is one filled with problems with bad posture and daily living and everything else, so it's often a problem down here. Right now, this patient doesn't have any radiating pain into his arms, just in the upper arms here again and in this area here. So it's the time to get him right now here. So what I want to do is normally I will scan him here and see how deep the tissues are. You're about the same size as me, so I know I have to go about 2 centimeters down to get the center of the deep paraspinal muscles and the posterior layer of the joint capsule. So I'm going to stimulate pain, these pain-producing fibers, which are actually active right now. So could you just take off your shirt? And we take our device. And it needs some gel. As a coupling agent, so the shockwaves can come out. So you use a little bit like this. Then you choose the right gel pad. I want 20 millimeters. That's where I want to center the beam. But the beam is about 20 millimeters long, so the shock wave will actually go 3 centimeters down. 1 to 3 centimeters, you'll have the shock wave. So I know this will not go into the spinal canal. It will stay at the target tissues. Of course, if I ultrasound scan, I can do very precisely.
Excuse me, I understand. This is a lady like me.
Yeah.
I shouldn't use the 20.
You should
right?
use one centimeter, yeah, as a general rule.
Yeah.
We have it here. And then you just lie down, eh? And I have some tissue. Yeah, take that up. Yeah. So what's specificity is the key to success. You have to stay at the same point if you want to create the right pain inhibition. So we are actually confronted with several problems. Skin moves, the patient moves, muscles tense up and relax. So that's why I have the patient lying down. I palpate the painful area. Is it here? Yep. Spinous process. So I want to go just lateral to them. And when you have to angle your beam of focus around the spine, you have to go slightly medially to get actually to the multifidi and to the joint capsule. The surrounding layer on top of the spinous process will actually trick you a little bit, so you have to go from lateral to medial. So I palpate this area. Here's the spinous process. Center. I go about a centimeter out. And here I have my target areas I want to treat. Normally you would treat a patient like this with some manual therapy, some physical therapy, exercises, but they keep on continuing having pain. So they have some neurology going wrong. Some tissues are still tensing up and causing pain, so they inhibit normal motion. So you want to inhibit these neurological signals. You want to do it centrally, and you want to do it at the spinal level and at the cortical level. So you have to cheat the body, and you have to deplete the postsynaptic chemical response, and you do that by overstimulating them. You had that for thousands of years. Here in China, acupuncture, we know that a painful stimulate can actually fool the nervous system to become less painful.
你如果有睇唔到，其實可以槍出嚟嘅，因為呢度都有啲位，大家可以睇得清楚啲。特別後面嗰啲朋友可以 face 2 minutes.
Yeah.
You want to
Come up here, all around me if you want.
all around.
We put a little bit of gel on the patient here. And now I tell my patients, you're going to feel a painful sensation. When I hit a spot which mimics the pain that you have, you tell me. And you give me a number between 0 and 10, where 10 is the most painful one, and 0 is no pain. And then I start out using the therapy unit here. So I know I'm at the right level here. Sometimes, if you don't get the patient response, you're probably using the wrong depth, or you're probably in the wrong place. So what you have to do is to search now. You have to search to regenerate the pain that the patient exhibits. Then you have to attack it, which is as high a dose as you can, between 0.2 and 0.3 millijoule, and you have to stay there until the pain starts dissipating. Then you can turn up the dosage a little bit and wait until the pain dissipates again, and until you actually desensitize the area. So I start with 3 or 4 in shock waves, in frequency, and you start out with 5 or 6. When you treat muscles, you often have to give it more energy than tendons and joints. So I start out here. So I look. The smart thing with this device is that you have a little knot here on the gel pad, and that you can use actually as a guide. So what I want to do is that I want to place it right over my skin marking, right here, and then I want to fixate with both hands. So I have my hands on the patient so it doesn't slide. And I'll tell you, we did some research where we actually colored this here, and we thought we were in the right place, but afterwards we could see we were actually moving it around. So you really have to pay attention to this. If you start moving around, you'll start a new pain sensation, and you're actually going to destroy what we're trying to do, to trick the body to have less pain and keep it permanently there. So I put it on again, then I hold it here. Can you feel any pain there? What level is it? Okay, if I just turn around like this, where is it the worst? Right there. I'm slightly medially angulated here, and I'm holding it here. It's 4, you say. I'm just going to increase it a little bit. And I increase the intensity and the frequency. How's the pain now? 6. I'm going to increase it a little bit more. Now? Okay, I'm going to stay here. You tell me when the pain dissipates and gets better. And you give me a number for it. Right now, all these little unmyelinated nerve fibers are firing very actively, both locally in the tissue and at the spinal level, and this goes to higher cortical areas. After a short while, they'll deplete. There won't be more neuropeptides at the nerve endings, at the end plates, and then you'll start to regulate the normal neurovascular functions of the nerve root again. How's the pain now? Still 6. Okay, still 6. So I'll go a little bit up. Now I'm at level 12. That's about 0.35 millijoules. So that's a 7. So that's my target area. Between 0.2, 0.4 millijoules, I know will have the proper effect, and I won't do any harm. You tell me when it dissipates a little bit again. Right, yeah. So you hold it on. I'm nearly at 700 shots. Normally I can stay there for 1,000, 2,000 shocks. Five. The first treatment is always the one that takes a long time. After that, they will dissipate much faster in pain response. And I really have to concentrate about being at the same spot all the time. So you have to be very disciplined about this. You can't sit and watch out the window and watch television or anything else. You have to really stay on here. Now, 6. We hold it on a little bit more. So I want to increase it a little bit more. And now. Sometimes you're able to get total pain-free perception from the patient just at the first treatment. Normally it takes 2 or 3 treatments, especially around the spine. It's more heavily innervated by nervous structures, so you have to treat a bit more times. That's why 3 treatments in general are not enough. Often it's about 6 treatments before you have full normal neurological function of the area. And now?
Any one spot.
Still 5, sorry?
At any one spot, what's the optimal number of shots?
I go around, me personally, I go about 2,000 or 3,000 shots. That's a bit more than others recommend, but I get much faster results, pain results. So I want to get this patient out of pain. I rather want to spend a bit more time the first and second treatment to get them out of pain.
Would that be overdosing? I mean, or like overheating him?
No, it doesn't seem to have any adverse effect. none has been registered. And with my colleagues in Germany who's done many thousands of patients, they have not had one adverse effect using the same protocol. So, and now? 4 to 5, okay. He's had 2,000 shocks. You can see there's a little indentation where my spot was, and you can still see it in the red circle, so I haven't moved it. And that's very, very important if you want to get quick pain response here again. So then I go a little bit down the dose. And then I go to the other area around here, on the other side of the spine. And I start here. Any pain there? How much is the pain? 5. 6. 6. You can see I can already increase the intensity. I'm already at 12 here. So I'm at the same end dose as I was before. Just now he's been pain inhibited. So this is a neurological way of stopping the pain pattern. And now I'm on 0.04 millijoules, and that's enough for me, and I'm just going to stay here for 2,000 shocks again. Any 6, so already now it's going down again. And I'm still holding it at the same place, not moving it at all. So some people complain about this headpiece is very heavy, but when you sit with it like this and just let it hold its own weight, even a slight woman can hold it. Never treat in a seated position or holding it, because you'll just injure yourself. So especially if you see a lot of patients. 5. So normally this here works exceptionally well with chronic back pains. After disc pathology, arthritic changes, facet joint pathology, which won't respond to normal physical therapy or manipulation or painkillers, pain medicine. 5. What you see too, if you strength test a guy like this with extension, he will be weak and painful normally. When you give this treatment here, afterwards they regain full strength nearly, and it's pain-free. So you actually normalize the tension and the function of the deep paraspinal muscles. So just give him a little bit more, just a little more patience. Pain now, what's that? 6. So we as manual therapists, physiotherapists, and manual medicine therapists and chiropractors, we often think we can treat everything by manipulation and exercise, but the spine often needs something else. 5. And 500 more shots. Do you feel pain anywhere else in your shoulder or?
Sometimes reducing to my posterior shoulder.
In the posterior shoulder?
And some thoracic area.
Okay. So we're in the right area around the muscle distribution here and the joint distribution. It doesn't go into the fingers and it doesn't go into the head. It stays here.
Sometimes under the scapula.
Under the scapula. So that's normal multifidi pain referral pattern and facet joint pattern here too. So we'll just So when this therapy is done, you write it down, the depth you treat it in, the energy level, the frequency, and luckily it stops automatically after 4,000 shots. So even if I looked away, and how long did it take? 5 minutes? So it didn't take very long. Now I want to press here. How does it feel? Already he said less pain here around here, so you get immediate. That won't last the first time, but if you continue this, after 3 treatments around the spine here, you'll get an amazing result when these biomechanical patterns actually have been there for a long time.
How often do you recommend? So how many days in between?
Yeah, I'm very aggressive. I treat twice a week.
Twice a week?
Because I'm not looking for regeneration of the tissues. I'm looking at pain reduction.
Right.
And we found that 2 or 3 times doesn't alter, but once a week causes inferior results to twice.
Right.
So that's in general our experience. So I'd rather treat for 2 weeks, and they are much better. And then they can start doing exercise, they can sit down and straighten up without having pain, and then they can start rehabilitation. So it makes everything more easy for them. Of course, you have to rule out other pathologies. Of course, hot disc needs rest and a lot of medication, non-steroidal anti-inflammatories, and sometimes nerve medicine too, like GABA, Pantene. And sometimes you need to use antidepressant drugs to relax them. But injectional therapy around the spine does not seem to be very effective, only short term, unfortunately.
If there are multi-trigger points, like if it has a shoulder pain as well
Yes.
together.
What I would have done beforehand, I would have palpated his trapeze, and normally he would have trigger points down here. If I press down here, always in the middle trapezius, if I press here, it will actually cause the pain. I would treat them too. But what you actually find, if you go to the root of the problem, these things would disappear by themselves because you normalize movement, and then the accessory muscles don't have to work to compensate for it. So find the root of the problem, because all the other trigger points you will find, but they might not be the main cause for this here. So save yourself a lot of time and do that. If you have some resistant trigger points who keep staying there, treat them afterwards. But just by doing this, you can sit up again and just sit here and just